There is always a discussion on PPHN in your Viva, so it's very important topic. So if you consider, we have questions related to transitional circulation, we have questions related to pathophysiology, hemodynamics, management aspect. In that management aspect, you have questions on vasodilator therapy. You have a question on inotropes in PPHN. You have a question on preterm BPD PPHN, and so on. So you can imagine that this is the most important topic when we consider about the hemodynamics in neonatology. So we will see that how we are trying to cover these topic in the various sections, and then we will go few things here and there. Depending upon the time factor, I will try to squeeze few points and I will try to go on to another points also. So I think you all are well versed, but still for important repetition, just concentrate on the fetal lung development. If we see the fetal lung development here, we have canalicular stage, we have saccular stage, alveolar stage, and then there is a postnatal part. As we all know, in the canalicular stage, we have very small blood vessels. We have few blood vessels, less cross-sectional area, and we have very high levels of vasoconstrictors. Hardly any vasodilators in this canalicular stage. So if you consider this canalicular stage in the fetus is in the stage of a fetal physiological pulmonary hypertension. So the first important concept you all need to understand that the fetus is in the state of physiological pulmonary hypertension. That is expected from the fetus and that is the need of the fetus. So if you see the saccular stage, that is 30 weeks onward, there is a more pulmonary vessels, area is increased, and still the pulmonary pressures are higher than the systemic pressure. Definitely slightly less pulmonary pressure than the 20 weeks, but still very high. If you see the stage, which is probably what we called as a late preterm or early term, where the vessels are increased, area is increased, but there are very, very high levels of vasoconstrictors. So when you say that very high levels of vasoconstrictors and very low levels of vasodilators, this is the stage where you have very high pulmonary vascular resistance. So when we consider this stage, we always request obstetric colleagues not to deliver this lady at 36 weeks, 37 weeks, 38 weeks. That is a late preterm or early term. Please avoid delivering these ones because the pulmonary pressures are quite high in that stage. So we also know that there is a normal transition. What happens in normal transition? There is a inflation of the lung. That is the first important thing we all know, and that has to happen. Ventilation of the lung has to happen before the clamping, and that's the concept of placental transfusion or delayed clamping. You allow the lungs to ventilate. Once you allow the lungs to ventilate, there is going to increase pulmonary blood flow. So ventilation, increase pulmonary blood flow. Ultimately, your pulmonary vascular resistance drops, and by clamping of the cord with the oxygen and nitric, you have increase in systemic vascular resistance. So this is very important stage. What we are talking now, there is a decrease in this pulmonary vascular resistance and increase in systemic vascular resistance. So in the postnatal phase, where you have almost only 13 to 20% of the cardiac output, which is going to the lung, now 80 to 90% of the cardiac output going to the lungs. So two things very important. Your cardiac output has shifted from probably the no lung to the lung, and what we all know, that there are three shunts. We know that ductus venosus, PFO, and at the level of PDA. These shunts play a very important role when we talk about the excuse me 1 minute. Abhinav Jalil को inform कर दो please. Sorry about that disturbance. I just usual time of the reporting of the hospitals, as you all know. So what I was trying to say that there is a shift of the blood flow. That means lungs fluid is replaced by the air, decrease in the pulmonary vascular resistance, increase in systemic vascular resistance. By main mechanism is the ventilation of the lung, oxygenation, and the use of nitric oxide. So these are the important thing happens when we discuss. So from fetus to neonatal, we are talking as opening of the lungs. We are talking as the clamping of the cord, naturally closure of the ductus venosus, closure of the PDA, and the closure of the PFO. These are the transitional circulation, which is the normal phenomenon happens in the newborn babies. If this normal phenomenon doesn't happen, then we are talking as there will be the persistent high pulmonary vascular resistance. And that normal physiological, if you see this pulmonary blood flow, there is a sudden increase in the pulmonary blood flow at the time of the birth. So what you are saying here is x-axis is your what we talk about fetus and after the birth, and the y-axis has pulmonary pressure, pulmonary blood flow, and vascular resistance. So there is a sudden rise in the pulmonary blood flow, which leads to the decrease in vascular resistance, ultimately decrease in the pulmonary artery pressure. So this is the normal transition from fetus to the neonatal period. And we also know that these are the factors which are important for inflation of the lung, oxygenation, and nitric. These are the factors which are responsible for decreasing the pulmonary vascular resistance. And if there is a problem with the inflation, that means too much inflation or underinflation, or the problem with the muscularization or problem with the compression, what we talk about maldevelopment, underdevelopment, or maladaptation. With severe hypoxia and acidosis, these are the detrimental factors for increased pulmonary vascular resistance. So these factors are main responsible when we consider about pathophysiology of PPHN. So what is this PPHN? It is nothing but your vascular resistance is high. That's why your pulmonary pressures are high, and they are associated with the bidirectional PDA. That's one shunt, or they are associated with the bidirectional or right to left PFO. So the shunts at the level of the PDA and the PFO, they will be bidirectional or right to left. That's first important concept what we need to understand. So the vascular resistance is high, pulmonary pressures are high, associated shunts are there. That leads to right ventricular function, ultimately left ventricular function. So the pulmonary hypertension is nothing but you have high vascular resistance, you have bidirectional right to left shunt, you have biventricular failure. So these three components you should understand. So when somebody talks you about the pulmonary hypertension, primary pulmonary hypertension, persistent pulmonary hypertension, think about what? That yes, I'm dealing with a high pulmonary pressure. That is one component. That high pulmonary pressures are associated with the shunts. These shunts are bidirectional or right to left at the PFO and PDA. Ultimately, the effect is on the heart, which leads to the right side failure, ultimately left side failure. If you understand that, then we know that we have a problems because of these antenatal factors like low Likert, renal problems leading to the severe oligohydramnias, water stasis, and pulmonary hypoplasia. These factors leading to the pulmonary hypertension. Or we have the transitional factors which leads to the pulmonary artery pressure. Those are common in India, or what we talk in the form of asphyxia, acidosis, or hypoxic respiratory failure. At the same time, we have intrinsic blockage of the vessel leading to the high pressure in the form of polycythemia. And all these leads to the very high pulmonary artery pressure. The commonest cause in Indian scenario, probably 80 to 90%, is a secondary pulmonary hypertension. And that secondary pulmonary hypertension is meconium asphyxia pneumonia, leading to the problems about the respiratory failure. And the rare, but there are problems in the form of left side dysfunction, pulmonary vein stenosis, leading to the pulmonary venous hypertension. So we could have pulmonary artery hypertension, we could have pulmonary venous hypertension, we could have problems of the lung inflations, we could have problems about the compression or maladaptation. These are the things theoretical, we know that. But the commonest emerging problem in India now is preterm BPD pulmonary hypertension. Level 3 units, those who are managing the babies who are what we talk less than 30 weeks in India, where you see the premature, extremely low birth weight babies with choriamnitis, and then this without steroids, with ventilation, with damage to the lungs because of the hyperoxia or hypocapnia, leads to inflammatory response. These inflammatory response has a dysregulation, leading to the issues related to the muscle, issues related to the vessel, issues related to the blood flow, ultimately leads to the pulmonary hypertension. So this is a big problem coming out, where you are having level 3 units, where you are managing a lot of babies less than 30 weeker, and a lot of these babies are preterm BPD pulmonary hypertension. I'm going to take a separate class on the preterm BPD pulmonary hypertension next month. I think a lot of you might be getting emails from my side or from my secretary. You will get that information. If you're not getting information, I'll be going to provide you my email ID and mobile number after the end of the session, that you can write down and send me the SMS. That's the next class about the preterm BPD pulmonary hypertension. I mentioned you guys that there is a lung disease, which we know that there is a hyperinflation or underinflation. There is a pulmonary vascular disease in cases because of the issues related to the growth, muscularization, or decreased blood flow with the vein stenosis, and associated heart disease in the form of right side dysfunction leading to left side dysfunction. All these three factors, lung, vessel, and heart, in the preterm, they will present as a high pulmonary artery pressures, and you will see that 34, 35, 36, 37 weaker, you might struggle with ventilation, you might struggle with non ventilation, you might struggle with weaning or oxygenation persistent. That problem is still there. So if you see, the most important component about the pulmonary vascular resistance is we are talking as hypoxic respiratory failure. So the most important thing here is a hypoxia. And this hypoxia leads to the acidosis, ultimately again increased PVR, shunting, and vicious cycle. So if somebody is talking about pulmonary hypertension, we should always think about hypoxia, acidosis, bidirectional or right to left shunt, and worsening condition. If we don't act fast, they will undergo that scenario repeatedly. So just now I mentioned that there is an increased pulmonary vascular resistance leading to the hypoxia and acidosis. These factors ultimately lead to the right-sided dysfunction. All these factors of right-sided dysfunction ultimately leads to the LV dysfunction, and that is a vicious cycle. And hence I told you that when we talk about high pulmonary vascular resistance, that means high pulmonary pressure, severe hypoxic failure associated with severe acidosis, leading to the biventricular failure. That's the most important pathophysiological component. If you understand this pathophysiological component, then it is easy for you to manage these patients. So just I mentioned, we have high pulmonary resistance, we have right side failure, and that right side failure leads to the left side failure and shock, and you require a lot of inotropic support in these babies. So systemic failure, systemic hypoperfusion and shock, these are the components you will end up in these babies. If you see the cardiac pathophysiology, the normally, as you know, as this is the normal blood flow, we talk RA to RV to then pulmonary to the lungs, veins, LA, LV that we know, and you have left to right duct and left to right PFO. But when there is a mild to moderate PPHN, we know that there is a high right ventricular systolic pressure. That leads to your TR jet with bidirectional shunts at PFO and PDA. That means you have increased right side afterload and increased contractility initial part. If this pulmonary hypertension worsens, then this shunts becomes only right side. And there is a shift of the septum or bowing of the septum to the left side. Naturally, your afterload increases, contractility decreases. If it still worsens, this LV becomes dysfunctional. So here, right-sided dysfunction started. Because of right-sided dysfunctional septal deviation, this septal deviation leads to the compression. There is a decreased LV preload. There is associated pulmonary venous hypertension. Decreased preload, increased pulmonary venous hypertension leads to this left-right shunt. So sometimes you will see that PFO, which is left to right, your PDA, which is right to left, your PD is right to left, and PFO could be left to right. That's a severe form of PPHN with RV dysfunction, with LV dysfunction. So do understand this important physiology that you are dealing with a heart dysfunction. You need to pick up before worsening of the heart. So this is just a revision what I told you, that in cases of the normal babies, you have normal afterload, mild to moderate afterload increases, severe definitely it increases. Contractility starts increasing, but later on it fails. Diastolic function initially decreased and then later on too much decreased. So systolic decrease, diastolic decrease, septum shifts from midline to the left side. PFO from left to right becomes bidirectional and pure right to left. And later on it could be left to right. PDA left to right becomes bidirectional and pure right to left. LV preload decreases, blood pressure decreases. So LV also fails. So we are talking about RV failure. We are talking about LV failure in severe form of PPHN. That's the main important thing what we are talking as a pathophysiological angle. We do talk about the labile hypoxia. So there is a labile hypoxia. As you all know, you all are treating, I don't have to discuss this, that baby doesn't like touch, baby doesn't like light, baby doesn't like handling, suction, movements. You want to keep these babies. Disproportionate hypoxia, difference between pre and post ductal saturations, more than 5, more than 10, you are in big trouble, murmur of TR jet, and naturally you have to do the hyperoxia test. But nowadays we don't do the hyperoxia test because of the availability of the bedside echo in most of the centers. You diagnose early, but if you don't have echo, then do the hyperoxia test. Along with that, naturally later on you do the hyperventilation test, and once your PO2 improves, naturally you are dealing with the sites where you are talking pulmonary. But if it doesn't improve, you have to hyperventilate, and still you are struggling. Ultimately, you have to do the echocardiography. That is what most important component. So when we discuss about the hemodynamics of the PPHN, we are talking about increased pulmonary resistance leading to the increased pulmonary artery pressure. How we are going to assess that? The increased pulmonary artery pressure mainly by catheterization, which is not available in a bed to bed. Hence, you have to measure right ventricular systolic pressure. And then ultimately you calculate pulmonary artery systolic pressure. Along with assessment of the pressures, you have to always assess right ventricular functions, left ventricular functions. So your echo doesn't finish without assessment of the heart function. Right ventricular systolic functions, right ventricular diastolic functions, left ventricular systolic functions, left ventricular diastolic functions. You all have to assess that. That is the approach. So assessment of the pressure, assessment of the shunt, assessment of these parameters are very important. And as you all know, the gold standard for the assessment is echocardiography to see these shunts, to see the TRJs, to see the septal deviation. Those are the ones associated with right and left sided functions of the heart. That's the full assessment when we talk about the functional echo. Now we'll come to that point. But when we talk about the functional echo, you have to assess the pressures. You have to assess the shunts. You have to assess the right-sided systolic diastolic. You have to assess left-sided systolic diastolic. That's your full echo when we talk about the babies, about the hemodynamics, about echocardiography. So in